Is it a bird? Is it a plane? No, it's the psychedelic renaissance in Europe. Not so long ago, these words were as imaginary as Superman, but suddenly, here we are. So please join me in welcoming our next panel, the Psychedelic Renaissance in Europe, Science, Policy and Practice.
Welcome to this panel today on which is termed the psychedelic resonance in Europe, Science, Practice and Policy. It's a true honor to be here with all of you today and also to share the stage with cutting-edge scientists in Europe, leading advocates and long-time clinical practitioners, and actually leaders in mental health in Europe. Thank you for coming and being here today, and thank you all. My name is Helga Zöega. I'm from Iceland. I'm a professor of public health and pharmacoepidemiology at the University of Iceland. And my research has mainly focused on real-world use of psychotropics, in particularly prescription medicines for mental health conditions, and especially in vulnerable populations that are seldom parts of randomized clinical trials. So it's really exciting for me to be at this conference and see developments in still somewhat an unregulated world of psychedelics. But we are here today to talk about the more kind of the medical model in Europe in terms of psychedelics. And we have 45 minutes on the stage, and I'd really love for us to aim for a dynamic conversation. You'll all have your opportunity to speak and provide good insights, but I also encourage you to riff off of each other and kind of try to form a flowing conversation within the aspects, or the three aspects of this panel, which is science, policy, and practice in Europe. Okay? So I think it's safe to say that there's an urgent and unmet need in terms of European mental health and within the system. And this is even true in a small, relatively prosperous country with a welfare state like here in Iceland. To some extent, we're all dealing with limited resources. And in that aspect, how might we see psychedelic therapy come into play in the medical model here in Europe and within the healthcare system? And with that in mind, I'd like to start with you, Tadeuz, as the founder and executive director of Parea. You've been dedicated to driving systemic change in Europe's healthcare, and in particular within the mental health space. This is your second panel today, so thank you so much for being here again. And obviously, there's a reason for that, I think, because we stand before, I think, a huge task when it comes to policy reform here in Europe. Could you kind of touch upon the work further that Parea is doing and kind of maybe tap into the current and potentially most imminent steps towards regulatory approval of psychedelic treatment, maybe taking MDMA and psilocybin as go ahead.
Okay, great. Hi, everyone. I'm really happy that we have this panel on Europe. I think we have a lot to share with all of you. And I also hope that what we'll discuss will be kind of conducive to a good digestion rather than any disruptions. So again, PAREA stands for Psychedelic Access and Research European Alliance. We focus on the future safe and effective implementation of these treatments into healthcare systems. And the first thing we do when we look at that is really trying to normalize the discussion about psychedelics and make people see them as normal medicines, as effective healthcare interventions. And the way we do it is, first of all, by the way we are structured as a membership. So we have 13 members, and I think we are unlike any other kind of psychedelic-related group globally, because we are not only representing psychedelic organizations, like our members include Beckley Foundation or ICEERS, but they also include, first and foremost, patient organizations, so people with lived experience, like Pain Alliance Europe, like European Federation of Neurological Associations, and two more. Our members include scientific societies. Among our board, we have the president of the European Psychiatric Association, past president of the European College of Neuropsychopharmacology, and so on. So I think this is really unique because it gives us a lot of representation and legitimacy as we engage with the EU policymakers. What we do is educate, but obviously we have a big emphasis on regulation, and we engage with the EU regulators, with European Medicines Agency or EMA. Earlier this month, we had a meeting in the European Parliament that we co-organized, where we relaunched our members of the European Parliament action group on psychedelics in healthcare, and it was done in conjunction, by the way, with the launch of the European Citizens Initiative Psychedelic Care. So just plugging here a plug for this campaign, Psychedelic Care. If you're in the EU, you can sign a petition. We want to collect 1 million signatures. What we've done so far, and this will kind of, I think, hopefully set the stage for further discussions, we catalyzed, for instance, 6.5 million euro in EU funding for psychedelics, so public money EU for a clinical trial, 4-year trial. There will be another trial, another call. We kind of convinced the European Medicines Agency to organize a workshop, which they did last year, 2 days workshop. And recently we were contacted by WHO. They invited us to form part of this revision on guidelines on controlled substances. So this shows that this model works if WHO invites you for collaboration. Now, coming back to the EMA, the way we will see psychedelics available is starting with EMA, because EMA has to first approve treatment, and then it can be, with some caveats, but it can be rolled out nationally. The challenge in Europe at the moment is that no major drug developers are having enough. We have a lot of great science, we have small clinical trials, but we don't have enough powered phase 3 pivotal trials that could lead to approval in the next few years. So I think we will probably not see a regulatory approval in this decade, really. Probably something in the next 3 years, hopefully in the US, and then we'll see. So that's, and I want to say that, interestingly, the European regulators are actually very supportive. EMA is doing their best to kind of convey what they are expecting of drug developers, and they are saying our doors are open, come, but yeah, it has to be kind of, tango that takes two to dance. So we have to be patient, I suppose. So maybe for now,
can I just briefly, in terms of collaboration between the European Medicines Agency and, for example, scientists, and I agree, it takes two to tango, and this is really important, that the dialogue is open, and it's open from early on. And I want to ask, and then hand over to you, Engilbert, what is the role of scientists? Should they just sit there and wait for EMA to say, oh, this is the strategic direction that we want you to take? or is it vice versa? Or how, I mean, just as in human life, like what's the interaction between the ground scientists and those who are creating the evidence base and the regulatory authorities?
Yeah, I think the scientists are a critical, they are a critical force in the future, you know, enabling access to these treatments, because it all starts with science, it all starts with clinical trials. Of course, with psychedelics, it started way back, you know, because we are kind of building this work on the indigenous knowledge, on the treatment protocols that acknowledge set and setting and so on, but then they are kind of used in scientific protocols. And so scientists are critical, but the problem is that you need science and a lot of money to conduct trials. So this is where companies are needed, because they are able to do this work.
And maybe like a strategic kind of thought process in terms of, okay, we need to unite. Engilbert Sigurðsson, you're a professor of psychiatry here in Iceland and a consulting psychiatrist at Landspitali, the university hospital. And would you like to kind of share your thoughts in terms of how, as a clinician, you viewed psychedelics, both in terms of the science, but also just in practice here in Iceland?
Yes, welcome. I'll do that, Helga. So, I mean, I've been reading articles in this field. I remember the first one that got me really interested. That was Carlos Sarate in 2006, ketamine and treatment-resistant depression. So I've been following this field ever since, more strongly since 2022, when Sara Maria started to prepare her first conference here in Iceland. And I've been sort of looking also into the phase 3 trials of Compass Pathways, the details there. I was considering taking place, but we didn't really have all the infrastructure required and the money that you were getting to recruit staff. It was too risky, and I just didn't feel that we could do it well enough. I think, and we have surveys to sort of back this up, that like the mental health professionals, especially the psychiatrists in Iceland, we are quite aware that we need a more broad approach in our treatments and a greater arsenal, like in treatment-resistant depression, in obviously PTSD, eating disorders, addictions. So I think they are open, provided that the evidence is there. And there we have to wait really for the FDA and the EMA. I have to say, though, just as a global citizen at the moment, I'm of course concerned about the FDA under the current health minister. So I hope just they will be able to do their best, because the EMA will always be looking to what they have been doing. And I think if those phase 3 trials are successfully completed and acknowledged both by the FDA and EMA, we won't have any difficulties with actually starting to integrate these therapies more into our regular treatments. I mean, we've been using ketamine now in the form of S-ketamine and Spravato for about, just over a year and a half. Could have started earlier, but there was COVID, and we're always also chronically short of money and staff here. We only put 5% of all our health expenditure into mental health, whereas Denmark, we are richer than Denmark, they use 10 to 12% of their health expenditure into mental health. So that is another challenge, but I feel that the sort of younger generation that is coming in is quite open, and they see this as just something that needs to be researched and looked into. But it's going to take, I think, still some time, and however, we have to be reminiscent of the past and the Schedule 1 allocation and all that, and when we get it approved this time, or get it approved properly, to do it well. So it is adopted, you know, widely in mental health.
Many have viewed Iceland as an ideal setting, or maybe even kind of like a test case for psychedelic development, or we could become leaders in this field. And we touched upon that in the last panel. Within the clinical models, like, do you have any envisions, or do you have any thoughts on this based on kind of you being a leader in mental health here in Iceland?
No, just as we could not compete, I think, in the electric car market with Tesla, we just don't have the infrastructure, the money, or, I mean, we can offer some visions, and there is a lot of discussion and debate that has been in society. There's a survey that was done on around 1,100 subjects in 2022 that showed that there's a lot of interest and a rather positive mood among those who have used these substances in Iceland. Much more positive than, for example, towards cocaine, just to compare. So I think that is unrealistic. I think we will have to follow sort of the mainstream big players and the approvals from the FDA and the EMA. That is my judgment.
Thank you. David, you're a psychiatrist and neuroscientist. You've already presented very elegantly yesterday. You're obviously a leading scientist here in Europe in terms of psychedelics and the psychedelic potential within mental health. And you've been doing research for over 15 years at Imperial College London. Thanks for the great overview that you brought us yesterday. I know you have some what do you say, you're interested in sharing something more with us and potentially a call to action. Would you like to dive into that now, or do you want to follow up on Engilbert?
Yeah, maybe to what you raised. Yeah, thank you. I think, in a way, my call to action is actually don't just sit and wait for the whole thing to be done and completed, because then it will take a long time to implement. But at the same time, I do totally recognize, in terms of the evidence base, it's not realistic for Iceland to step in and do massive trials as well, and therefore shortcut anything. But you can prepare the system. And actually, I sit right next to a really good, maybe the best example I can think of in Europe, and particularly in the north, who has done it very, very well. You were clapping yesterday for very good reason. I was also clapping, of Lowan. What is happening in Norway. That is very viable model that we will hear more from Lowan about what is being done. And stuff like that can be done. And it can even be done even more focused and strategic if we go beyond just ketamine. So my call to action is, so I came up with psychedelic therapy system deep dive, but that is abbreviated PTSD, so that's a bad one. So therefore, instead, maybe structural preparation for psychedelic therapy. And what I mean with that is that we have started bringing some people together, some US people who have been involved with maps and with government in the US and reimbursement strategies in the US, together with people from Europe and UK, trying to do a little bit of working group to try and find out how can we learn from obstacles, challenges, even maybe mistakes, and get it a little bit more right, and try to do it on a national level. To Tadeuz's point about it might not happen in this decade, maybe not. I can see why as well. UK, there might be, I don't know if there's silver lining of Brexit, but in a way the UK is not bound by EMA because of Brexit. Not that I really don't like Brexit, but that could actually be an advantage, but they could potentially decide to rubber stamp FDA and actually implement it a bit quicker in the UK. So the UK, we need to get our act together, and as a lot of you know, and we have at Imperial and also other institutions in the UK been incredibly active in studying the drug, but that's not the same at finding out something about the brain or doing proof of concept trials. That's not the same as getting it out into clinical practice or prepare the clinical systems, the NHS in the UK, to actually implement them. So I think what we need to do is do some, what did I call it, structural preparation for psychedelic therapy task force in each country. So if I was a philanthropist or spoke to one at the moment, I think maybe instead of doing a lot of trials that we don't know whether they actually serve a purpose in getting them through. We don't know what trials will be needed in Germany as a comparison trial. They need that. EMA might require this and that trial. We don't actually know exactly. We need to speak much more with the EMA to find that out. But instead of spending a lot of effort and doing long-scale, massive trials, spend a lot of money, we should still do some of that. But some money could be allocated to a group of 2 to 3 people in each country not psychedelic people, not like us, but people who are system people who are experts in how to bring in a new treatment into the national health system, how to do that successfully, what are the route, how do we do it, how do we navigate, how do we prepare, and how do you prepare the different professional bodies. The Psychiatrists organization, Royal College in the UK, or equivalents in other, the psychologists, the nursing, those bodies that look after their staff, how do you make sure that they will be certified in the right way? How will they be monitored? How will there be complaint routes? How will you make sure that their practice is good enough? Those structures do not exist. If I was a regulator, even if the data look great, then you need that to be prepared. Somebody needs to do that work. So I think each country should have task force like that, and then they should be linked on a European level to help each other. But it has to happen on a national level because the systems are different. So I think that's right now a focus of myself and some people around us, and we are using that ketamine model as a little example, as a pilot example of how it could be done. I mentioned it yesterday, very briefly, I'll mention it again. Lowan has intellectually supported it, so has Kyle Greenway with the Montreal model from McGill, and also Pedro Rodriguez and Owen Winfield from Awaken, because we all agree on the model. So we think we want to protect the beauty of the psychedelic model. We want to protect and harvest all the fruits possible for these drugs, which is not do a biological reduced Spravato model. It's doing, if you use ketamine, do it in a psychologically, therapeutically enriched model, and the same with the psychedelics. Let's not just sit back and wait for companies squeezing their model through the regulatory process where the psychology is stripped off because they have to, because of strategies. We need to be prepared to implement them into the right setting, and I think that the little ketamine pilot we are doing might be a good one, because what we are doing there, we are taking an existing structure within the NHS, which is the talking therapy service locally in that trust. There are 80 psychologists working in that service. We are then coming in with our ketamine pilot right next to it, collaborating with those therapists, convincing them that I'm a biological psychiatrist, I'm convincing a psychology service that you shouldn't do a biological model, you should do a psychological model. That's very easy, so I can recommend that approach. Then you get them on board, and they have co-ownership of this. They will then the patients will be identified from the talking therapy services. The most difficult, the most stuck patients, the ones that fulfill criteria for treatment resistant. They have tried a couple of different antidepressants. They might have had 1, 2, 3, 4, 5 courses of talking therapy. They're still depressed. Those are the patients you identify them in that service. You work with that service. You keep them under that service and get weekly therapy while you're coming in on the side with the, in this case, ketamine, but the same can apply to MDMA and psilocybin. You put it in the right place into the system in existing structures, enrich and support and help train those structures. You have co-supervision between the psychiatrist that you don't need many of because they're just giving the ketamine once a week, but the therapy is done by existing therapy services. That, I think, is a valuable model. I think that's why Owen, even Rupert McShane in the UK said the other day he thinks it's a good model. He has set it up 15 years ago, ketamine, but in a very biological way because he set it up in the ECT side of things, which was logical at that point. Now we are somewhere else where we want to implement it together with talking therapy, enrich the model, protect the model, and then that is scalable, we believe it is. Then you need, as part of that task force, you need a health economic person who knows how to calculate health economic and cost-benefit analysis in healthcare. You need that kind of little group. Then you can have a group around them of psychedelically informed clinicians, therapists and psychiatrists and so on, and scientists to help that group. But it should be driven by people who understand systems and health economics. Otherwise, it's not going to be successful in any country. If you invite people with power into this kind of meeting in order to convince them, I don't think they're going to get convinced. They're going to get confused. I love this kind of meeting. I think it's a beautiful thing. It's important we all meet, but we need to be careful and not confusing it too much if you invite people with decision power who can, on a system level, implement it. They will get confused when you mix in drug policy and access to all and fair legal structures and deregulate. I agree with all that, but it's a separate issue, and you cannot confuse the two. If you need to, it needs to be focused, and the strategy needs to be clear. So I think in a way we need to separate a bit the medicalized model that I and Lowan and others are part of. And it's not that we don't like the rest of you guys. We should still meet and have amazing party time and meetings and exchange ideas and meet and brainstorm together. But that is not what is going to make the change. You need to understand and work within the systems and get the systems right, have expertise. And that's not even me or Lowan. We need to work with people who understand those in order to help. And then we can work together across those national bodies. And it can only be a couple of people, and then experts around, and then we can work with Parea and on an EU level as well. Anyway, that was my long call to action, sorry.
Lowan, I'd like to thank you for being here today, and you gave a compelling overview of your clinical insights of working with ketamine-assisted treatment for almost 10 years now, am I right? Both in Norway and the US. And I'd want to kind of maybe see if we can expand a little bit onto the psychotherapeutic component of the ketamine-assisted treatment that is now being provided in Norway. What does that consist of? How is the training of the therapist? Is it centralized? And would you propose kind of like a centralized approach in the psychological therapy component for other psychedelics? Or do you feel that this is something that should be kept looser and not be involved in the drug regulatory system?
Yeah, thank you. I'll get to that answer. First, I wanted to say I agree with everything that David just said. So I think, as Tadeuz said, that so we have to keep in mind that the other psychedelics, the classics and MDMA, are not going to be approved for some time. Maybe it's a few years, maybe it's longer. But that means that we will still not have widespread access in public healthcare systems for a long time. And what that means is there are millions of people who are suffering, who are deeply suffering, and do not have access to safe and free care that could potentially really help them. Outside of, with those drugs, outside of compassionate use programs and clinical research trials, or in countries where they legalize. But what we have to remember that we have a drug that has been approved, has been legal for over 50 years. And despite the differences, as I spoke about before, there's many similarities. And most importantly, ketamine is an effective drug that helps many of the same mental health disorders that the others appear to be effective for as well. But it's the model that you have to have in place for doing ketamine treatment and ketamine-assisted psychotherapy is basically the exact same model and infrastructure that we will need in place when those other drugs get approved. So, if it's several or many years before the other drugs come online, it's going to be, if we wait to have that infrastructure in place, then it'll be another couple years. It takes a lot of time. It takes a lot of work to, any new health technology, any new treatment process where you have to pay attention to different, it doesn't just fit nicely like a key into the current psychiatric model of just, giving somebody a prescription. You have to have a space for that. You have to pay attention to the context, to the set and setting. You have to set up a whole process of staff, personnel, training that's involved, and setting up a protocol that fits well in a particular healthcare system. And in some places like the UK, where they have all kinds of different sub-healthcare systems, that it's very, very complicated. So people are suffering right now. We have one of these many effective tools already available. The model is analogous to how we treat all these other medications, how they're used. And so what we need to do is what I think everybody should be doing now is implementing ketamine into their current health systems immediately. And we don't have to reinvent the wheel. I mean, this is something that's been done for a long time. There's many different places that have been successful, and we can share the knowledge that we have from these processes that we've gone through, the protocols. We can set up working groups like David was talking about. We can talk to each other and make this happen right now and help the people that need to be helped right now. Just to answer your question about psychotherapy, so when you're integrating it, so in terms of the public health system, in the private sector, you can do it in the best way possible, and you have that autonomy to do whatever you want to do. In public infrastructure, you have to work within the constraints of that system. When we started the public unit in Norway, luckily, when we started it, I had already had a lot of many years of experience. So we built in the psychedelic informed model into the treatment itself. So from day one, that was built into how we offered the actual treatment session. And we set it up so that in order to do the treatment, that you cannot qualify for, so in private treatment, you get psychotherapy at the clinic with a trained psychotherapy. And ketamine-assisted psychotherapy, we use ACT as a model in the private. But in the public, what we did is we said you cannot get into the public treatment unless you already have a current psychotherapist set up. So that they have continual psychotherapy throughout the process, and if it's not set up, they have access to it. So in a public health system, we give them access to a psychologist or a psychiatrist who sees them on a weekly basis. So they have that continuity both before, during, and after the treatment.
Yeah. And this, of course, is a huge paradigm shift that I think many of us are grappling with, is how we combine the medicine component and the psychotherapeutic component. And I think all of us here on stage today can agree that these really need to work together. How to squeeze them through the system is another question, and that's kind of what we're grappling with here. Maybe not the most sexy conversation, but really, really important nonetheless. I just wanted to briefly follow up, Lowan. The ketamine that you're providing, is that S-ketamine or the already approved nasal spray, or are you providing ketamine in a different form?
Yeah, so similar to what happened so we provide racemic ketamine, so it's generic, super cheap. I mean, it's like $1 a treatment as far as the drug itself. The current understanding of the comparison between the two is that Spravato certainly isn't any better. So Spravato, the nasal S-ketamine, left-handed molecule, and there's not great evidence that the anti-suicidal effect is better than placebo for Spravato. So there's no reason to actually use Spravato, the approved one. And now, just to say, so that's approved for that indication.
Got it.
Whereas ketamine, generic ketamine, is an approved drug, but to use it for anything other than anesthesia is called off-label, which is normal practice. And I think in the United States, like 30% of all psychiatric prescriptions are off-label. But so we use.
I think David wants to jump in.
Yeah.
Just because not only is there no need based on the evidence for Spravato, I think we could actually dig a bit of a trap for ourselves. It's not because I have any anti-stocks, anything against the company behind Spravato. It's not because of that. It's because the model they're using, if that is what is being implemented, then we are, in a way, only paving the way for the non-therapy enriched version for the other psychedelics. So if we do what we are piloting, you are doing, Greenway is doing in Canada successfully, and we get more evidence for that it benefits more enriching it with psychotherapy and attaching it to psychotherapy services that exist already. If that is done with ketamine now, then you are much more paving the way for the correct and best and most appropriate, most ethical, and most protective of the model implementation of the other psychedelics. So it's not just because we sit here and hate Johnson & Johnson or whoever developed Spravato, it's because we're possibly doing ourselves a disfavor if we do not get it right now and expand that model and implement that with ketamine. It serves, you could call it Trojan horse, then that would be a tricky term, triggering probably for some regulators to call it a Trojan horse, but it is a little bit of a Trojan horse, and it's a very meaningful Trojan horse because it works. We need more evidence that it works better than the non-psychotherapy enriched model.
Thank you. So to you, Orla, Mallon, welcome to the stage. You're a cognitive neuroscientist working at the Center for Psychedelic Research at Imperial College as well. And at the moment, you're leading the neuroimaging arm of UK's first clinical trial integrating psychedelics into the treatment of opioid dependency. So we haven't really been discussing specific patient populations here on the stage. But I wanted to ask you, do you think we could make like a case or a strategic case for addiction, in particularly opioid dependence, as a strategic clinical focus for psychedelic research and practice here in Europe? Could you kind of expand on what you've been doing maybe in terms of research, but also kind of if you think this could become a scalable model here in Europe?
Sure, thank you. Yeah, I want to echo everything that the panel's been saying, David's been saying, Lowan's been saying. And as Lowan was saying, there's a lot of people who need help out there. And in psychiatry, addiction is the biggest unmet clinical need. So there are a lot of people out there who need help in addiction broadly, opioids specifically, but really just across the board. And I think as we start to prepare the systems and we start to try and work with the systems, we also kind of have to think about the populations that we're speaking with. And this is where it's really important to consider like how we've been focusing a lot, MAPS has done a lot of work with PTSD, we've been doing a lot with treatment-resistant depression, But addiction is a very different, it's a very different population to work with. It's also, from a systems perspective, a very difficult sell in many places. So this is something that David and I have been working with in the NHS as well, or with different services, and you see a real divide between their opinion towards psychedelics, mainly because they're very scared that there's addictive properties, or they just want to avoid anything that's psychoactive. So as we start to move towards working with the systems, we really have to think about which populations. And I think addiction is really an area that it would be great to get psychedelic-assisted therapy sooner, but that is going to have to take us working within the systems early. It's working with them now and figuring out how does that model work. And for example, one of the things that we've been thinking a lot about at Imperial is, you know, many models of addiction, they bring, they have a lot of peer support.
Yes.
And this is something that we wanted to reflect in the model. So something that we've come up with, we wanted to work in a group element. And for various reasons, after many discussions, we determined we couldn't do that in this trial. But we've come up with wanting to use a dyad of one therapist and one person with lived experience. And I guess we would hope that as psychedelic-assisted therapy, very similar to the ketamine model, I think it should be the same, implemented within the services, not reinventing the wheel. But as part of that, to bring people with lived experience into the process and specifically bring them into helping in that therapy, perhaps as a dyad, similar to as AA or other peer support models have.
Yeah. Very interesting. Touching upon that, Tadeuz, like within Parea, how good is the representation of lived experience with addiction? Do you have good access or membership of patient populations or dealing with addiction?
So yeah, so the difficulty is that we don't have really at the European level kind of federations or patient groups bringing in addiction, so we have to find other ways. But I also want to build a little bit on what David and Lowan said. So we build a lot of momentum in Europe, but you know there is this gap before something can be approved. So we think a lot what we can do, and indeed, you know, we think that we should be doing something now, and we also see that we need to somehow meet regulators because, for instance, there was the Dutch State Commission on MDMA, and they made recommendations to have naturalistic studies. But then the health ministry in the Netherlands said, wait a moment, let's just follow the regular path. Why we should make any exceptions here? So they will put a few million euros maybe for a clinical trial. So there are fundamental challenges in terms of how we can engage with regulators, but there are ways we can explore, and there is a new kind of tool in the toolbox that will be approved in the next couple of years, which is called regulatory sandboxes, where we could have some kind of EU coordinated mechanism to test therapeutic approaches that do not fit neatly into existing models. And I think that ketamine could be explored as one, and actually this is one of the key priorities in the coming years in our strategic plan. One is sandboxes, and the other is seeing ketamine as a healing agent, but also as a proxy for psychedelics. So we'd like to organize a meeting in the European Parliament towards the end of the year, also bringing in European Medicines Agency because we are in touch with them and kind of discussing what's possible. So already kind of issue an invitation to you, Lowan and David, to kind of brainstorm and start preparing for that meeting.
One follow-up question with you, Orla. Within opioid dependency, I forgot to ask, the psychedelic that you're mainly working with, is it psilocybin, or are you doing anything with ketamine as well? Or
no, this trial is in psilocybin.
Yeah. That's what I suspected. But yeah, go ahead.
No, just you can maybe mention more Celia's.
Yeah,
go
but
ahead.
we work, well, in the UK we're all quite friendly in the addiction squad. But Celia Morgan is conducting a phase 3 trial using ketamine for alcohol use dependency. So ketamine is being used there as well, but our trial, both on opioid dependency and also gambling, is using psilocybin therapy. Yeah.
Thanks. I think it's safe to say that collaboration between the scientists, clinicians, and regulatory agencies is essential in our field, and probably more now than ever. Just one final closing remark from you, Engilbert, in terms of Iceland. Is there something you want to add in the last 30 seconds?
Well, I do agree with Lowan about his strategy, and I, for one, have actually planned trips this year where we are not with Sara Maria, but to clinics outside Iceland to see how they are working with the ketamine model, not in the Spravato way, but we needed to start with Spravato. It's just the way we have to go forward. But I think if we then can continue doing what you are doing, we are sort of laying the groundwork for the future. So it's very good to have your invitation to share, what you've been doing, and that is the next step.
You are invited to Oslo.
Speaking as a Danish person, I deeply regret on behalf of my country, with small country, energy country, that Lowan fell in love with a Norwegian, not a Danish person. Seriously, because it's not happening in Denmark. Clone Lowan, because that, anyway.
Anyhow. Thank you so much. I think, patience, persistence, but collaboration. These are things that we need to aim for. Thank you all for being here today.